Ultimately, others chimed in. So you see this piece in Politico raising the same concern. So I wasn't alone, but most of the time it felt pretty lonely. The other clear indicator that knowledge isn't power is what's been happening with the obesity pandemic. We can talk about the epidemic in the United States, but this too is pandemic. Sadly, we've been very effective at exporting the major causes of obesity along with the causes of chronic disease. The CDC has been tracking the prevalence of obesity in the US with color-coded maps for 40 years. So you note the date here, this is 1985. So I'm just going to show you the trends. And I'm going to front load by noting how unbelievably frustrating this is for me personally. 1985 is the year I started medical school. And when I came out of medical school and residency and ultimately my second residency, I pledged myself as a young person to do something about this, to change the trajectory because it had already been bad for a while. And I'm just going to show you how monumentally I and the others who signed up for that mission have failed. So note the colors, and you can see down at the bottom an indication of what the prevalence is. Less than 10% obesity, 10% to 14% back in 1985. Okay, this is 1990. So everything has darkened, meaning more higher prevalence. This is 1995. We introduce a new color, 15 to 19%, because the prior colors weren't adequate anymore. This is 2000, yet another color, more than 20% prevalence of obesity, meaning more than 20% of the residents of a given state are obese, not just overweight, but actually obese. 2010, two new colors introduced, greater than 25%, greater than 30%. Color change on these maps is never a good thing. 2012, a whole new set of colors because now we go up to 50% prevalence, although thankfully no state here is showing that, but we're anticipating it. 2022, we now have some states showing those really dark colors where we're up near 50%. Half the population of the entire state is obese, and every state has a higher prevalence of obesity than was even anywhere on the map back in 1985. This is the trajectory over 40 years. And as I indicated, we are, alas, very good, very adept at exporting the causes of epidemic obesity. So it's epidemic around the world. It's a pandemic. The United States is arguably the epicenter, although frankly, there are a few nations not shown here on this chart that may be worse off than we are, in particular, the nations that have gone through a very rapid cultural transition in the Middle East, like Kuwait, the United Arab Emirates, Qatar. Basically, people adapted to a frugal diet and a desert lifestyle who suddenly became very affluent on oil money, and their lifestyle changed completely and their diets changed completely, and rates of obesity and diabetes and all the rest of the metabolic mayhem exploded. And when we examine worldwide trends now, so this was a very recent paper, this was in the Lancet, look at the date, February 29th, 2024, so basically a month ago, roughly, worldwide trends in underweight and overweight. The conclusion reached here is that this data set indicates more than half of the total global population will be overweight or obese within the next decade, roughly. Absolutely incredible. We long ago, 2006, if memory serves, crossed a threshold where there were more overweight and obese people than hungry people in the world, although they're not mutually exclusive because food insecurity and essentially some varieties of hunger and obesity can go together. But overt hunger, lack of calories, and obesity do not go together. There are more obese people than hungry people in the world. That was pivot point. Obviously, both of those things are bad. But now, more than half of the total global population, more than 4 billion people, overweight or obese. So just an unbelievable, massive problem. And yet one we knew how to fix all along if we cared to do it. We just obviously don't. And back to the pandemic again, I'll weave in and out of it as appropriate. Obesity was recognized as a major driver of differences in mortality in countries around the world. In other words, obesity per se was a risk factor for bad outcomes in SARS-CoV-2. I volunteered on the front lines of COVID early in the pandemic. I worked in the Bronx in an emergency room, and I saw this. I saw, other things being equal, patients coming in who had higher weights were doing less well, and it was also more difficult. We were already aware of the importance of repositioning people, and that's hard enough to do on a gurney in the emergency room with somebody who's small, but somebody who is larger, and there's less room to turn, it was difficult for them, it was difficult for the staff, and consequently we were doing less good a job of aerating their lungs. So many reasons, some of them mechanical, some of them immunologic, why obesity was a driver of international differences. We also find now that obesity is on the list of risk factors for long COVID, which is the phase of the pandemic we're currently in, where this is a major public health concern. And we can talk more about this in the Q&A if you're so inclined. Colleague and I published this paper in Frontiers in Public Health, pointing out that despite this clear association between obesity and bad COVID outcomes, both acutely and in the long term, it's actually a more nuanced story than it appears to be, because consider this, for instance, obesity tracks with indigence in affluent countries, but it tracks with affluence in indigent countries. I'll unpack that just to make sure you get it. So here in the United States, everybody is at risk of obesity, but that risk is much greater in underserved communities and people who have resource poor environments, where the only choice is a bad choice, where there's a fast food franchise everywhere, but there's no Whole Foods, for instance. So relative indigence puts people at greater risk of obesity in our affluent nation. But in an indigent nation where there really isn't much over consumption and food scarcity for many people is just a typical day, and people are struggling to get enough, the affluent are much more likely to have access to plenty. It's a rarefied privilege. That's the way it used to be in history, where obesity was the privilege of the aristocracy. So you still see that pattern in indigent nations, relatively low-income nations around the world. Well, if you are affluent in an indigent part of the world, you have better access to all kinds of resources, not just food, but medical care and hospitals and drugs. And the result is that obesity in poor nations is associated with better COVID outcomes. So it's a subtle, nuanced, interesting story. Like so many things about the pandemic, it's nuanced, and we're very bad as a nation at addressing nuance. We gravitate to the poles, we go left, we go right, we call one another names. We don't stop to listen. We don't think about nuance. We would be much better for it if we could rediscover nuance in this internet, social media age, and listen to one another and agree to disagree at times, but maybe learn something by hearing opinions we don't already own. Really important. So that was the case we made in this paper. I move on. Most importantly is not the direct effect of obesity on the outcome with SARS-CoV-2 infection or anything else, but the indirect effect. So this has a fancy name, a flexible copula approach. It's really just looking at a range of interactions that could account for chronic disease outcomes in association with obesity. And the conclusion reached in this very large study, looking at millions and millions of people across an expanse of published literature, is that obesity is causally contributing to the vast toll of chronic disease in the modern world. So it's a major risk factor for chronic disease. And that was acutely relevant during the pandemic because these chronic diseases, notably hypertension, diabetes, coronary disease, were the major determinants of the toll of COVID. So this was a modeling study in the Journal of the American Heart Association, as you see, looking at how much of the COVID mayhem was attributable to essentially the prior pandemic of cardiometabolic disease. And for those of you who want to dig in here, I commend the paper to your attention. It's very sophisticated and quite good, but I'll just give you the punchline for today's purposes, 60%. What that translates to is, had we effectively addressed the prior pandemic of cardiometabolic disease, even if we had done nothing directly against SARS-CoV-2, even if we had not used masks and had not had vaccines, if we had simply been a healthier nation coming into the pandemic, 60% less hospitalization, 60% less death. Could have cut the toll of COVID by more than half just by indirectly defending ourselves. And of course, I'm not saying that's what we should have done. If we indirectly defended and directly defended, we could have done much better still. This is not a talk per se about COVID, but important to note that these cardiometabolic diseases were a major driver of the toll of the pandemic. So the way to think of all this is that obesity isn't really the disease. It's a canary in the coal mine of chronic disease. And in light of the pandemic, we could argue perhaps a canary in the coal mine of acute disease as well, the acute outcomes that we witnessed during the pandemic. Where there is more obesity, there is more type 2 diabetes, metabolic syndrome, hypertension, dyslipidemia, inflammation, coronary disease, and all the rest. And where there's more of that, there's more premature death. And some of that is due to acute infectious disease. And as a result of all of this, obesity is more and more being thought of as a disease in its own right. So some years back, this is 2013, so a decade ago, the American Medical Association formally recognized obesity as a disease. Now, their intentions were good here. The idea was we don't blame the victims of coronary disease, we treat them. And one would hope with compassion. Whether well or not is something this audience could debate, but we treat them and we don't blame them. And we don't blame people for their hypertension. We could, in a sense, because these are very much lifestyle related, but we don't do that. We respect the condition in medicine and we treat it with the customary compassion, whatever that is, but not so obesity. Obesity is associated with words like laziness and gluttony. We blame it on people's character, and that's fundamentally wrong. And we can get back into this in the Q&A if you like, but it's fundamentally wrong. Victim blaming is wrong. And the AMA recognized that this was happening routinely. By the way, it's still happening routinely.